Hello everyone, welcome to my video channel. As promised, my topic today is surgical site infection SSI part 1. In this video, we should be able to answer the question 1. What is the definition of surgical site infection SSI? How do you classify surgical site infection? Number 3. What are the risk factors for surgical site infection? It can be divided into A. Patient factor, B. Surgery factor. Number 4. Define surgical site infection in an implant-related patient. Number 5. The management of each wound classification. So, what are the definition of surgical site infection? Surgical site infection SSI is an infection that occurs in the incision created by an invasive surgical procedure. It's defined by Centers of Disease Control and Prevention (CDC). Post-operative wound infection or surgical site infection is defined as an infection that typically occur within 30 days of an operation at the site or part of the body where the surgery took place, or within a year if an implant is left in place and the infection is thought to be secondary to the surgery. Surgical site infection SSI can be defined based on the tissue involved. A. Superficial surgical site infection that is limited to the skin and subcutaneous tissue. B. Deep surgical site infection whereby it affecting the facial and muscular layers. C. Cavity space infection occur within an abdominal or joint cavity. Bacterial colonization on the patient's skin and alimentary and genital tract are the contributing sources that lead to surgical site infection. In the picture of the right-hand side, it depicts the picture of the classification of the wound. For superficial incisional wound, it only involves the skin and subcutaneous tissue. For deep incisional wound, it involves the deep soft tissue. For organ wound, it involves any part of the anatomy other than incision open or organ that is being manipulated. The organism include the commonest is Staphylococcus aureus, followed by coagulase negative staphylococci, E. coli, E. faecalis, Pseudomonas aeruginosa, Enterobacter, and lastly Klebsiella. For wound classification, number 1, a clean wound. It is defined as an uninfected operative wound in which no inflammation is encountered and the respiratory, alimentary, and genitourinary tract is not entered. Examples include elective inguinal hernia, non-penetrating blunt trauma. The risk of surgical site infection is around 2.1% in clean wound. It is based on the NNIS American study. NNIS stands for the National Nosocomial Infection Surveillance System Risk Score. For wound class 2, clean-contaminated. Definition: an operative wound in which the respiratory, alimentary, or genitourinary tracts are entered under controlled condition and without unusual contamination, provided there is no evidence of infection or major break in the technique is encountered. Example, elective colon resection. The rate of surgical site infection is around 3.3% based on an NIS study. For wound class 3, contaminated wound. Definition: a wound in which gross contamination or spillage and a break in sterile technique is and has occurs. An incision in which acute non-purulent inflammation is encountered. Example: penetrating trauma with gross intestinal spillage. The rate of surgical site infection is around 6.4% based on an NIS study. For wound class 4, dirty wound. It is defined as a wound that is already considered infected, such as all traumatic wound with retained devitalized tissue or perforated viscera. Examples include intra-abdominal abscess, acute bacterial peritonitis. The risk of surgical site infection is around 7.1% based on the NNIS study. What are the risk factors for surgical site infection? It can be divided into A. Patient or host factors. B. Surgery, surgical or operative factors. Let's start with A. Patient or host factors. These factors include 1. Advanced age more than 65 years old. 2. Diabetes mellitus, especially uncontrolled diabetes mellitus. 3. Obesity. 4. Cancer, whereby the host become immunosuppressive. 5. Altered immune response, example in HIV or AIDS patient, immunosuppressive in patient who is using an immunosuppressive drugs. 6. Smoking or tobacco use. I have already explained the reasons for each of the factors in my video of the wound healing. 7. Poor nutritional status. Patient is having a hypoalbuminemia. 8. Poor functional status. Example, patient is bedbound. He or she tends to develop complication of prolonged bedridden. 9. Coexisting infection at non-surgical site where there is already a pre-existing bacteremia. 10. Previous abdominal procedure. Again, part of this patient factor have been explained in my previous videos. For B, surgical or operative factors. 1. It started off as a contaminated or dirty wound in the first place, so the rate of infection is already higher. 2. Significant tissue trauma, example in a closed crush injury. 3. Inadequate surgical scrub or skin preparation that leave the commensal organism on the skin to go through the open wound. 4. Preoperative shaving that leads to injury on the surface of the skin. 5. Inappropriate antimicrobial prophylaxis that does not properly cover the commensal. 6. Poor aseptic technique that lead to a breach in sterility. 7. Inadequate tissue oxygenation. I already covered regarding oxygen supplementation in the surgical site infection video part 3. 8. Poor operating room ventilation. 9. Open technique surgery that leads to a higher risk compared to a closed technique. 10. Prolonged operative time, especially more than 2 hours of surgery. 11. The need for blood transfusion intraoperatively. Also, I already explained this reason in my previous video. And lastly, 12. Foreign body insertion, example, mesh, implants, or prosthesis. What are the signs and symptoms of surgical site infection? Well, any surgical site infection may cause fever, pain, tenderness, warm swelling, redness, and delayed wound healing. The majority of surgical site infection, excluding the surgical site infection involving implants, are diagnosed after discharge, but within 3 weeks from the operation. For superficial surgical site infection, the margins of the site should be marked in order to observe the signs of progression. The presence of systemic signs of infection, wound or tissue and blood samples for gram stain, culture and sensitivity and susceptibility should be obtained and help in guiding the therapy. Any drainage should be sampled and sent off for a gram stain and culture. Laboratory, a complete blood cell count with differential, C-reactive protein, and basic metabolic panel to assess for creatinine or renal insufficiency and any metabolic or electrolyte abnormalities. Again, superficial or incisional surgical site infection is defined as an infection involving only the skin or subcutaneous tissue occurring within 30 days of an operation. It needs at least one of the following must be present to diagnose a superficial or incisional surgical site infection. Number 1, diagnosis by the surgeon or the attending physician. Number 2, purulent drainage with or without laboratory confirmation from the surgical site. Number 3, either aseptically obtained culture from tissue or fluid demonstrating causative organism. Number 4, presence of symptoms such as pain or tenderness, redness, localized swelling or heat, and the site is opened by the surgeon if the culture is positive. What are the management of superficial incisional wound? We can start off with an oral antibiotic in the case of uncomplicated superficial. Example, cellulitis without surgical intervention and debridement. Antimicrobial therapy is recommended for 5 days and extended if clinical signs of infection persist or worsen. Incision and drainage for complicated infection. For deep tissue or deep incisional surgical site infection, it involves the deep soft tissues including the fascia and muscle layers of the incision and occurs within 30 days after the operation or within a year if an implant is in place and the infection appears to be associated with the surgery. Additionally, one of the following must be present. Number 1, the diagnosis by the surgeon or the attending physician. Number 2, purulent drainage from the deep tissue site but not from a deeper source. Example, from the organ space. As illustrated by the X-ray, infection can occur post-plating radius and ulna. Additionally, to diagnose a deep tissue or deep incisional surgical site infection, one of the following must be present. 3. The deep incision is either opened by the surgeon in the settings of sign and symptom of infection. Example, whereby patient develop fever more than 38 degree, tenderness, pain, or the hisses spontaneously. Number 4, evidence of infection. Example, abscess is identified during the workout or management or by histopathologic or radiological examination. For an organ space of surgical site infection, it involved the abdominal cavity that was manipulated during surgery and occurs within 30 days after the operation or within 1 year if an implant is left in place. Furthermore, the infection appears to be related to the surgery but does not involve the superficial incision. One of the following must be present to diagnose an organ space surgical site infection. 1. Diagnosis by the surgeon or by the attending physician. Number 2, evidence of infection, example abscess, is identified during the workup or management by histopathologic and radiologic examination. Number 3, aseptically obtained culture by tissue or fluid demonstrating the causative organism. Number 4, purulent drainage from the cavity as from a percutaneously placed drain or during reoperation. Management of deep incisional and organ space. In order to effectively treat a surgical site infection, antibiotics and anatomical source control is necessary. Source control is achieved through the surgical, example operative debridement, or procedural, example intravenous percutaneous drainage intervention. Empiric systemic antibiotic should be started as soon as a deep or organ space surgical site infection is suspected and when there's a signs of infection are present. That is, patient having a fever more than 38.5 degrees Celsius, abnormal vital signs, erythema, and induration extending more than 5 cm from the wound edge. White blood cell count more than 12,000 per microliter. The type and duration of empiric antimicrobial therapy is based upon expected pathogens, which is determined by clinical presentation, anatomic site, comorbidities, and physical examination. The antibiotics then tailored to the culture results as when the result is available. Okay, so far, commonest organism are Staph aureus and Coagulus negative staphylococci. The first line of empiric therapy consists of a first-generation cephalosporin, example cefazolin, for MRSA, methicillin-resistant Staph aureus, vancomycin and linezolid or other equivalent antibiotic is administered instead. For the gram-negative and mixed organism, example Pseudomonas aeruginosa, Enterococcus species, E. coli, the treatment of choice include a broad-spectrum antimicrobial coverage, example vancomycin plus piperacillin, or tazobactam, or imipenem, or meropenem, and cephalosporin or fluoroquinolone plus metronidazole. Yay, we have come to the end of our video. I hope you have learned something from this topic. See you again. Bye.